Hey guys, so this is wrist, hand, and finger pathologies part 2. Um, Again, I apologize that it's not going to be full screen, but my computer will allow that, and let's hope that third time's the charm, and this one will post. It told me it posted Friday, and then I found out today that people weren't able to see it, so we're going to do it again. So wrist sprains. Wrist sprain, mechanism of injury, like it says, trauma forcing wrist into end range of motion. So that can be wrist flexion, extension, ulnar or radial deviation. So really any direction but forcing it into that position, which puts a stretch on the ligaments. So signs and symptoms of wrist sprain. Again, wrist and forearm and even metacarpal injuries and carpal injuries. A lot of times it can be hard to differentiate because they do have a lot of similar signs and symptoms when it comes to the injury. So knowing the anatomy, palpation is definitely key. So again, signs and symptoms, active range of motion is limited due to pain. So depending on which way they injured, their mechanism of injury. Passive range of motion will often produce pain, so putting a stretch on the ligaments. Again, ruling out other conditions. A lot of times mechanism of injury can help you do this. Positive valgus and varus stress tests, depending on, again, the way that they commonly fell on the arm or hit something, or maybe even holding an implement and struck something can cause a wrist sprain. So again, these images show radial collateral and ulnar collateral ligament stress tests of the wrist, so valgus stress and varus stress. A lot of times they say the best way to do it is to have someone put their forearm on a table. That way it stabilizes better. A lot of times someone's just holding it. You might get more, twisting, pronation, supination. But if you put them on the table, that limits that, and you make sure you're just getting the wrist range of motion. So kind of like when you're measuring wrist range of motion, put them on the table and have their wrist and hand hang off the side. Make sure they're relaxed. Then again, a valgus stress is applied, and that radially deviates the wrist, and that is testing the UCL. And a varus stress, which causing ulnar deviation, tests the RCL. These tests are considered positive if there's pain or if you sense laxity. The best way to do that is oftentimes compare bilaterally. Some instances you may have wrist sprain of both. Say you're working with a gymnast who did a tumble or movement wrong. Maybe they did the same thing to both wrists. But again, make sure we're still comparing bilaterally. The more tests you practice on a very varying group of people, the better idea you'll have of what is normal versus abnormal, and what the laxity should or should not be like in a wrist. So TFCC injury stands for triangular fibrocartilage complex, which you should have learned about in your anatomy portion. Mechanism of injury is fouche, so fall and outstretched hand, and into forced hyperextension, so putting that hand back. Usually upper extremity, so closed kinetic chain position. So more common, again, in a gymnast, if someone falls on their hands, wrestling, even a football player. So that fibrocartilage, that complex, made up a group of ligaments and then also the disc. So some ligaments are dorsal radial, palmar radial ligament, and then again the articular disc. So that disc kind of reminds me, if you've had lower, of a meniscus. It sits right there in that groove. It has a vascular area and non-vascular. So that can be torn or damaged along with stretching the ligaments that make up that complex. As you can see in the picture, again, here is the triangular, the fibrocartilage complex on that ulnar side. And again, mechanism of injury is forced hyperextension. So putting that person into hyperextension will cause pain, oftentimes decrease range of motion. pain or clicking, especially if they've done damage to that disc or if there's laxity in the ligaments. Pain with ADLs, so if they have torn something, picking things up, something as simply as taking grocery bags, maybe even driving. Pain with weight bearing, so any kind of weightlifting or holding things in their hand. Maybe if they're pushing on something, push a door open, they might have pain. So positive ulnar grind. Again, kind of if you know what the McMurray's is when the knee, testing the meniscus. So you put pressure down through that TFCC area, push and rotate back and forth, and sometimes you can get a grind almost, and you can feel the cartilage damage. And again, you want to rule out, make sure be aware there's no avulsion fracture of the styloid process. So if you do get a positive grind, what is clicking. Is there a piece of bone in there that's chipped off? So if it is severe enough, oftentimes it is a good idea to go ahead and get x-rays to rule out any further damage. Next is one that all of you have probably heard of, carpal tunnel syndrome. So mechanism of injury, repetitive microtraumas. It's common, and a lot of people say secretary injury or older women. It's when it was first called carpal tunnel. I believe they also called it like a typewriter injury. People typing all day, secretaries taking notes, things like that, just that repetitive use. And it creates the carpal tunnel symptoms, which is nerve numbness and pain due to that median nerve being compressed, which obviously lies in the carpal tunnel. As you can see in this image here, all the tendons and also that nerve go through, and that transverse carpal ligament goes atop of it. So repetitive force and trauma. Again, typing a lot. I've seen baseball players who've had this from repetitive hitting or pitching. They might flick their wrists at the end, and it can cause inflammation in that area. And again, that inflammation will squeeze down on this median nerve, can cause a numbness, tingling, and pain. So paresthesia, pain along median nerve. Symptoms occur at night. They say because the blood flow isn't as great. Also, a lot of times people sleep and their wrists are bent. Extreme version, you might have atrophy of the thenar muscles because the median nerve goes to those. Positive Tinel sign and Phelan's test. You may also have decreased grip strength again because of impingement on that nerve. So you want to rule out proximal neuropathy of the median nerve. Make sure there's not something in the upper at the elbow or shoulder that's causing this as well. You can run EMG nerve tests. I have several athletes who've had that done. And what they do, they take needles. It is pretty painful, but they stick it up in the brachial plexus area and test the nerve function throughout the rest of the arm. If signals are being transmitted fluently, or if there's some kind of disruption because of nerve damage. Treatment's usually pretty conservative. A lot of times they'll give someone probably a pretty strong steroid or anti-inflammatory, tell them to rest, obviously not use that wrist, and then also bracing them, especially at night or when they don't need to use that. It's not necessary to use the arm. Put them in a brace so they're not having a lot of wrist flexion, extension, pronation, supination, etc. Severe cases, again, the atrophy of the thenar, and then also surgery. Surgery is pretty basic, pretty straightforward. So if we go back to the previous slide, you can see that transverse carpal ligament. A lot of times they'll just kind of slit that, a part of that, to allow more space for that median nerve. If there is some scar tissue buildup or any other kind of damage, they will clear that out. But usually it's a pretty successful surgery, and they can continue on, brace for a little bit, maybe some light rehab, but go back to their work. With that, when they cut that ligament, a lot of times this will not reoccur. If someone has it on one wrist, it's often, especially if they do a job where they're using their arms and hands, things like that a lot, it is common that it'll occur in the opposite wrist as well. Again, way to test for this, I call it, some people say Phelan's test for carpal tunnel modification. So in the first picture, the girls do it manually by herself, which works pretty well, but also they could, if they have any kind of shoulder or elbow impingement issues, they could be, it could show a false positive if they have impingement in their shoulders. So you can see she's holding it all the way up here, and the elbows are at 90. So maybe it's not just testing the wrist, the median nerve at the wrist, but it could be impinging it elsewhere in the arm. This is the original test on the right side where you do it manually for the athlete. You can have them do it seated or standing. You put pressure, so that's going to cause impingement on that median nerve. They say to do it for about a minute, usually tingling in the fingers, hand, and also sometimes it's painful. Usually if someone has had this issue, it doesn't take even a minute. It probably takes less than 30 seconds for them to go numb or have any kind of tingling. A reverse Phelan's test is the dorsal side, so they would put their hands together almost like they're praying, and you can get a positive test that way as well. So next we're going to talk about metacarpal fractures, mechanism of injury, compressive force. Punching improperly is the example on this slide, getting hit, compressive again, so a crush kind of injury, something drops on the hand. So you might hear a snap, there might be a gross deformity, so you could see a bone sticking out, localized swelling and point tenderness along that bone. It's very easy to have a lot of swelling. There's a lot of tissues in between your metacarpals, but definitely it's usually point tender along that bone. Long bone compression test is positive along with percussion tap. A lot of people also use a tuning fork for this test, so when you send that vibration through, if there is a fracture there, it'll vibrate together and it causes a lot of pain. Make sure you do these tests bilaterally, compare the hands bilaterally, so you can really tell if there's a significant difference. Some people just have different hands, may have bumps in different places. Also see if they've had previous injuries to their hand, which may account for scar tissue buildup elsewhere. So always important to compare bilaterally. So treatment, metacarpal fractures. So if the bone isn't rotated, if it's, maybe what they consider a hairline fracture, it's not displaced at all, put them in cast. Sometimes they even just do braces these days. If there is a rotation of the bone, you will need to most likely have surgery, so ORF, open reduction internal fixation. They will go in there and probably pin it back together, because if you let it heal twisted, then it's a very high chance that you'll have arthritis later on and can have issues with the function of your hand. It can disrupt ligaments, nerves running through there, etc. A common one is a boxer's fracture, so that's the fourth and fifth metacarpal. That commonly occurs, again, so if you picture someone making a fist, the knuckles would be along here, so most of the pressure is going right through these bones. So boxer's fracture, if they're punching incorrectly and they hit with the outside of their hand, it will snap fourth, fifth, or both metacarpals. So next are finger fractures. Most common of the distal phalanx are the first and third, just because of the location and how they stick out. So signs and symptoms, again, similar to metacarpal, point tender, swelling, hematoma, a lot of pain, may have decreased range of motion because of pain, depending on how bad the fracture is. Again, that could also cause decreased range of motion. ADLs, things like that. Again, look at the mechanism of injury. Someone can get hit by a ball, crushed in a car door, maybe just fell. It can really be any of those. So spiral or oblique fractures. So finger flexion, affected finger will rotate. So again, like it sounds, a spiral fracture, you might be able to see that their knuckle is twisted and doesn't line up with the rest, or their DIP and PIP joints. So you kind of look and compare, and you know, a lot of times they'll look and be like, "That's not that's not what my finger looked like before. Something's not right." Again, we get X-ray to rule that out. A lot of times fingers, if there's not any kind of rotation, depending on, you know, where is in the bone, it does heal on their own. Brace them. If it's a kid, a lot of times they'll put it in the cast, so they're not using it as much. But a simple finger splint, maybe even with a buddy tape job, and you're pretty much good to go. If it is more extreme, again, you might have to have surgery, but overall it's pretty straightforward. So finger collateral ligament injuries. So you most likely see these when people say, you know, maybe that they jam their finger. They can be causing damage to the ligaments. So that axial load. Valgus and varus stress, so they get hit with a ball or an implement from the side, forcing them into, again, a valgus or varus position, which can rupture the ligaments. So a lot of pain, a lot of swelling at that joint, positive valgus and varus stress, so more laxity compared to other fingers. You can measure finger range of motion. It's not done commonly, just because it's a hard area to compare, and some people do have pretty lax fingers or are considered double jointed. But one thing, when you do get that, you do get a lot of swelling around that joint. So a lot of people, when their, you know, fingers jam, you know, you could also have torn tissue. You get a lot of swelling. You got to get that swelling out of there. Compression wrap. Try to, you know, buddy tape to limit valgus varus stress. Make sure it's padding if they are going to continue to play sports. So again, in this image shows them doing valgus varus at the PIP joint. Also be aware, you know, just because they have pain right along that joint doesn't mean that they haven't fractured elsewhere. So a lot of times a long bone compression might be positive for pain because you are putting pressure through that joint area. So next, de Quervain syndrome. That's tenosynovitis of the extensor pollicis brevis and adductor pollicis longus. So they kind of share the same sheath and lining. So tenosynovitis is inflammation of that area. This is, well, what I've heard is called as a gamer's thumb. So people who play PlayStation, Xbox, Game Boy, all that, you know, might get, it's more common than you think, get inflammation from that repetitive motion, and it can be pretty painful. So again, mechanism injury, repetitive stress, inflammation. It inflames that sheath, and that sheath can also become thickened, and that decreases can decrease the range of motion by not letting that tendon slide smoothly through there. Pain and swelling. So this is kind of more of a chronic thing. Doesn't necessarily, you know, wouldn't happen all of a sudden as with a fracture, but pain with overall thumb range of motion. You can do Finkelstein's, I call it Finkelstein's test or Finkelstein's. Oh yeah, okay, they show it here. So you grasp the thumb and then go into ulnar deviation. A lot of you, if you try that, will have, you know, it doesn't feel comfortable at all. I'm doing it right now. It doesn't feel comfortable on either hand. But if you do try it and someone does have, again, de Quervain's, then it will, you know, light them up even more. So rest, ice, NSAIDs, you can give them thumb splints. Iontophoresis, which is directly putting the steroid into the spot where it hurts most. And again, activity modification is your best bet. Here again is an image of Finkelstein's test for de Quervain's. Fairly easy to do. People can do it on their own. But again, it's going to light them up quite a bit. You can also even feel, maybe they do have a buildup of that sheath and it feels thicker on one hand than another. But overall, you kind of look at their mechanism of injury or what their habits are, and that's one way you can diagnose this. So next, thumb sprains. I said gamer's thumb for de Quervain's, and thumb sprains are considered gamekeeper's thumb. So UCL, most commonly injured, as you can see in this here. So like a goalie in soccer tries to catch the ball, and it's put back into kind of like a hyper extension and abduction of the MCP, and it can tear that UCL or put a strain on it. So repetitive stress can limit the range of motion, swelling, opposition, so not able to pinch or tap the thumb to each finger. Can be, pretty painful. A lot of people, a couple volleyball players who've had this, and they will wear thumb splints, especially, middle blockers is common. They jump up, block a ball, thumbs get hit again and again and again. So not necessarily a one-time thing, but that repetitive over time, thumbs are going to get sore. So it doesn't hurt to tape or brace it to give it a little bit extra support. Pain, valgus stress test is positive for pain, and there also can be gapping at that joint. So, thumbs, that area of the thumb usually has a, pretty good range of motion anyway, so compare bilaterally to get the best guesstimate to see if there is laxity. Again, here are images of splints that you can use. Obviously, it doesn't just slide on by itself. Maybe if you're a goalie or you're in a sport where you do wear gloves, you can put this or this on and put your gloves on. Athletes I've worked with have a strap that go all the way around in the back side of the hand, and it stays on. They get them molded to their hands, fits well, stays well, and they seem to like it, and it works out for them. So treatment of thumb sprains, incomplete tear. So there's a firm endpoint. Their thumb just doesn't keep going. I know there are, again, a lot of people who have a lot of flexibility in their thumb, probably can bend it back and touch, their forearm. But if there is an endpoint, you can splint it for 4 to 6 weeks. Like I said, some people can play through this. It depends on their pain tolerance and how they're doing with NSAIDs and rehab. If there is a complete rupture, then you need to have surgery to get that fixed. The reason it says early surgical repairs, if you don't, then that ligament, can scar down, or a lot of scar tissue in there, and it can eventually, decrease your range of motion depending on how it scars down, or you're going to have a lax thumb for a long time and, lose the ability to maybe grip things as well if it is not repaired. So test for laxity of the thumb NCP joint. So putting pressure right along that joint, pushing, doing a valgus and varus stress. Again, to determine if there is laxity and if there is a sprain of that thumb. So thumb fractures. Again, with that repetitive stress, like we talked about with gamekeeper's thumb just previously, over time you can develop stress fractures if your hand is getting hit. If someone has dislocated area of their thumb, fracture. If you do fracture your thumb, that commonly requires surgery. Since it isn't, stabilized like the metacarpals and fingers are, they're all right next to each other and kind of stabilize each other, thumbs out on its own. So as you can see here, that's a pretty large fracture. Probably would not heal back correctly and would lose range of motion and possibly function in that thumb. So they would do surgery to most likely pin that back down, make sure it's in place. Cast someone, definitely would be out for a while. I personally have never seen a thumb surgery, but definitely a big deal. If you've ever tried to do things without your thumb, definitely makes it a lot harder. So getting surgery done and x-rays and imaging to know what's going on quickly is very important. So that is it for the second part of wrist, hand, and finger pathology. If you have any quick questions, feel free to ask when you see me in class. Thanks.